morning, everyone. Thank you for joining us today for the kickoff of the Bipartisan Policy Center's examination into improving and expanding access to the program of all-inclusive care for the elderly, commonly known as, of course, PACE. I'm Bill Hoagland, I'm Senior Vice President here with the Center, and work with our health and economic teams as we continually search for bipartisan solutions to some of these challenging issues that face decision makers and legislatures in the healthcare arena. I don't think there's any question that COVID has clearly revealed just how important this particular program is to the nearly 58,000 elderly persons it serves today. But we believe at BPC it can serve and do more to address the growing number of senior citizens in assuring their healthcare needs are met in the future. For the last decade here at BPC, we have focused on improving chronic care and long-term care for those with complex health needs. This work has included a range of federal policy solutions to first improve access to long-term services and support, both for Medicaid beneficiaries and for middle-income individuals who may not be eligible for Medicaid. Second, we've focused on how to simplify and streamline Medicaid authorities for home and community-based healthcare services. And finally, we have worked to try to find better ways to integrate the care for people who are duly eligible for Medicare and Medicaid. And last fall, in a report guaranteeing integrated care for dual eligible individuals, we recommended that PACE serve as one of three care models that states could consider adopting to guarantee fully integrated care for Medicare and Medicaid beneficiaries, given that nearly 90% of PACE participants are duly eligible. We also concluded in that report that expanding PACE was limited by the startup costs associated with establishing adult care centers and various eligibility restrictions. So today we want to explore some of these limitations to expanding PACE and finding new opportunities to help Medicare and Medicaid beneficiaries live safely and independently in their homes and communities through PACE. Many of the issues we will discuss today will inform a new report that BPC will release later this summer. The work will be led by Lisa Hartulian under the direction of Marilyn Serapini, our Director of BPC Health Project. Finally, on behalf of BPC, I extend thanks to the Robert Wood Johnson Foundation for their support of today's event and this ongoing work. PACE has a long history of bipartisan support in Congress, and we will begin our discussion today by hearing from two of our health program leaders, former Republican Senator Majority Leader Bill Frist and former Democratic Senate Majority Leader Tom Daschle. Let me now turn this over to Senator Dr. Bill Frist. He was a primary author of the PACE legislation in 1997. And on a personal note, he was my last boss on Capitol Hill. So, Senator Frist.
Good morning. This work to improve and expand access to the PACE model is coming at a very important time. The last 2 years of the pandemic have shown us just how necessary it is to ensure that a continuum of care options exists for those who need long-term services and supports. As COVID spread quickly through nursing homes and other congregate care settings early in the pandemic, it became clear that a shift toward home and community-based options would be necessary to keep our most vulnerable populations safe. PACE is a unique program that provides coordinated, integrated Medicare and Medicaid services, including those long-term services and supports, in a community-based setting. PACE traditionally utilizes adult day centers, but many of them had to shut down during the pandemic. Many PACE sites developed creative and innovative ways to provide care safely in the home, thanks to the flexibilities of the PACE model. While I was in the Senate, I co-sponsored the PACE Coverage Act, which ultimately passed as a part of the Balanced Budget Act of 1997, thanks to a bipartisan effort. This law made PACE a permanent, recognized provider type under both Medicare and Medicaid, and this created a runway for the creation of these programs nationwide. Today, 142 PACE programs operate 272 PACE centers across the country, serving right around 55,000 people. While all this is great progress, I believe that now is the time to consider additional policy changes that can improve and expand access to PACE. And I commend the Bipartisan Policy Center for pursuing this work. Now I'd like to introduce BPC co-founder and my former colleague from the Senate, former Majority Leader Tom Daschle.
Well, thank you, Bill. And I also applaud the BPC for convening this very timely discussion. PACE is a bipartisan solution to a complex issue that has only become more pressing amid the COVID-19 pandemic. Many from both sides of the aisle agree that it's important to provide quality care to people where they like to receive it. And that's why over the years, legislation involving PACE has received bipartisan and bicameral support in Congress. PACE programs have a long history. They've provided important care now for over 50 years, since the model first began in the 1970s as a program in San Francisco known then as On Lock, which still exists today, actually. Since then, we've seen the value of the PACE model in reducing the need for costly, long-term care in institutional settings, reducing preventable hospitalizations, producing Medicare savings, and generating high beneficiary satisfaction. The history of PACE serves as an example, really, of the success that can be achieved, even today, through bipartisanship. So I want to commend the Bipartisan Policy Center for their ongoing work on this issue. And I hope that Democrats and Republicans will continue to work together to advance the success of PACE. So now it is my pleasure to hand it off to Catherine Hempstead, the Senior Policy Advisor at the Robert Wood Johnson Foundation. Catherine?
Thank you and good morning, everyone. I'm really excited to be able to welcome everyone to this event today and really looking forward to kicking off some new work on this important program. PACE is a comprehensive model of care that integrates acute medical and long-term care services. And the focus is really timely because I think there's been a growing recognition of the importance of integrated models, both because of the recent events of the pandemic and also just the more longer term growing awareness of the importance of incorporating social needs into healthcare. And I think that we saw the recent makesPACE report on integrated care for duals as another example of the increasing awareness that by integrating care, we can meet people's needs better and also potentially reduce spending. Today's program, we're going to hear an overview of the PACE program, its bipartisan history, how it started, who it serves, and where it fits into the continuum of long-term care services. We're also going to hear about the value of PACE to beneficiaries and hear a little bit about the beneficiary experience. And then we're going to talk about the challenges, why it's been hard to scale and spread PACE so that it can serve more people. And importantly, talk about some of the new policy opportunities that BPC is working on developing so that we can bring this program to more people. On behalf of the foundation, it's really wonderful to be here because as some people may know, RWJF has a really long history in PACE and was supporting PACE and funding projects more than 20 years ago, long before I was here. But it's really great to see this renewed interest in PACE. And I'm looking forward to today's event and working with others to help bring this program so that it can serve more people. And with that, I'll turn it to Sheila Burke to start our discussion. Thank you.
Many thanks, Kathy. It is, in fact, a great pleasure to be with all of you today as well. As has been pointed out, this is a program that has been in place for many years, has tremendous support, and has done extraordinary work over the period of time it's been in existence. We are grateful for all of our speakers who are with us today and are looking forward to talking with them about the questions that Kathy has asked, about the history, about what we might do going forward. And essentially, this will help us kick off at the Bipartisan Policy Center a long-standing sort of history of work with more work to be done to improve care for individuals with complex needs. I am honored to serve as a senior advisor to the Bipartisan Policy Center. My name is Sheila Burke. I came to BPC some years ago at the invitations of Senator Dole and Senator Baker, but have a long history with the PACE program as well. And so I'm awfully glad to be able to talk with you about that today. What we're going to do today, I'm going to introduce each of our speakers, but we're going to very quickly get into a conversation with them, but we will be certain to leave ample time at the very end of the program to allow you to ask questions as well. So I would encourage you to add questions to the chat box, and we will get to those towards the end. And I've encouraged each of our speakers to consider this a conversation. Our goal is to sort of pose a series of questions to them, but allow them to talk among themselves as well. So we have the benefit of their input on each of these issues as we discuss them. So let me quickly talk with you about who's joining us today. We are really very blessed with the folks that we have that have unique experience and knowledge in this area. Peter Fitzgerald is the Executive Vice President of Policy and Strategy at the National PACE Association. In that position, he helps guide the association's policy and advocacy work at both the federal and state level. One of the critical issues here, of course, is that intersection of federal and state activity and involvement and engagement. It could not be done on one level without having support of the other. He leads the PACE 2.0 initiative to expand the access and use of PACE nationally. And prior to essentially his current position, served as the Senior Vice President for Integrated Care Strategies at Volunteers for America. Sonia Felton is the other person with us. She's the Executive Director of Huron Valley PACE, which is located in Ypsilanti, Michigan. And since joining PACE in 2014, she's held the position of medical social worker case manager, center director, and most recently as the interim executive director. So has, again, on the ground real experience with essentially the challenges facing the program and the individuals we serve. And then finally, Jenny Chin Hansen. Near and dear to my own heart. I've known Jenny for many, many years. She is in fact a very seasoned healthcare leader, currently serves on the board of a number of healthcare and system boards relating to healthcare and care transformation and quality. But again, I think most interesting to us is very recently she served as a stakeholder to California's Department of Health and Human Services to develop the state's first ever master plan for aging. From 2010 to 2015, she was the CEO of the American Geriatrics Association, where she led a group of nearly 6,000 healthcare professionals devoted to really looking at these questions and helping to address the issues of the aging in our population. And she also served as president of the AARP, having left that position in 2010. But prior to all of that, and notable for our conversation today, she served nearly 25 years with ONLOC. It is, in fact, as was described, a nonprofit family of organizations providing integrated comprehensive community care in San Francisco, California, in the Chinese community. And it became essentially the prototype upon which we built PACE. And so her experience with that program and the knowledge that she gained in running the ONLOC program has helped, one, move it to statute and move it to law, the coverage that we have today, but also as well as there are the challenges that we faced then and the challenges we continue to face today. And then finally, Ginny also served on MedPAC. So she's also looked at it from that perspective as well, in terms of the role of Congress and the role of Medicare program in supporting this program. So what I'd like to do is begin our conversation with a little bit of the history and an overview of the PACE program, just to give you some context. And I'm going to start with Jenny. And again, we've heard the origins of PACE, which began with ONLOC. But again, tell us a little bit, Jenny, about that experience, about what led us to where we are today. And then I'm going to ask both Sonia and Peter to comment as well.
our audience that when Sheila herself mentioned her long history with us, but for Sheila, when she was the chief for Senator Dole, she and he helped carry this initial attempt at legislation to the attention of Congress. So Sheila, we're delighted that here you are in this role today with us, but your history is actually quite significant for the fact that PACE exists. So the question about how the program started, it's interesting because the discussion today is about population health, communities and all. Here, PACE is, or Unlock actually is almost 50 years old in terms of its history. And it started in the community by planning, thinking about a region. So it included the Chinese community, of course, because this was Northeast San Francisco, but it also served the community in that district, which included North Beach, or the Italian American, as well as Filipino Americans. So that was actually, when we talk about diversity, this was diversity at the onset. Long and short of it was that people needed to be cared for at the level of a nursing home organization. There were no beds, so to speak. And so people from that district would end up going 30 to 50 miles away. And so you can imagine being at this stage of one's life to be totally torn away from your community in terms of its own neighborhood, the language, the food, the customs. Short aspect is the idea of whether or not to build a nursing home. And we were lucky to come across a geriatrician from Oxford, England, who said, no, don't build a nursing home. He said, do what we have in England, and that is have a day hospital where people come during the daytime for services, but they go home and sleep in their own beds. And so that started this reframing of what nursing home level care could be. And so it grew, and it started with two individuals whose backgrounds I think is very significant to point out for its DNA. Marie-Louise Anzac, who was a social worker, and Dr. William G., who was a community public health dentist. So interesting to take note, this was not a medical program from the onset. And the fact that we're talking about social well-being, dental health, as well as functional services and the whole medical and clinical. The medical and clinical came on afterwards. So I think that was an interesting consideration of stacking and developing a program, not clinical and all about hospitalizations, but it's like how to help people stay in the community. So that's the essence. Fast forward, the original national studies were successful. So the idea of advancing it. So we had some supportive legislation to test it out. And Robert Wood Johnson, as noted before, was very key in helping funding the initial sites that we had. There were 7 around the country, all in different environments, from Boston to South Carolina, to Portland, Oregon, to Denver, to El Paso, Texas, with very different populations. Also, of course, Milwaukee and the Bronx, New York. But it tells you that this was a very diverse set of different communities. Success came about. We were lucky to get sponsorship and bipartisanship, because we were around the country and we were able to show evidence of its effectiveness, as well as have a chance then to be fortunate to have the legislation passed under the Balanced Budget Act in 1997. So that's kind of the start of it, and it grew. The PACE Association came about for working with multiple sites, and you'll hear from my colleagues, of course, of their particular dimensions and their roles of what they have made PACE be what it is today.
Terrific. Thank you so much, Jenny. Sonia, help people understand who's eligible for PACE. Jenny described the sort of community that they began with. But today, who are we looking at in terms of eligibility? And then I'm going to ask Peter to talk a little bit about where does PACE fit in sort of the continuum as we look at the services provided to people over a period of time.
Yes, so for an individual to be eligible for PACE, they must be 55 or older, live within the PACE service area, meet the state, their eligibility requirement, their assessment for nursing home eligibility, and that differs in different states, what tools they utilize. And also the individual must be able to live safely in the community with the support of PACE services.
And so again, we see from state to state that things vary, which is one of the challenges we'll talk about when we talk about some of the barriers to PACE as well.
Yes.
Peter? I'm sorry, Sonia, did you want to add?
No, I just agree. Yes.
Okay, Peter? A little bit about how it fits in the continuum and what makes it unique as compared to other models.
I think what makes PACE unique remarkably after a 50-year tradition is that we're still at the forefront in terms of fully integrating coverage and fully integrating payment. And as Jenny referenced in the history, both of those features of the model were created with the intent of enabling fully integrated care. So when I look at the history of PACE, what drove its innovation was simply trying to address the needs of a population. And they discovered essentially capitation, and they discovered integrated coverage along the way as the means to the end of treating or responding to the needs of an individual holistically. But we continue to be at a time when many policymakers are seeking to change the healthcare system to make it more integrated, to bring the Medicare and Medicaid programs together more. We continue to be at the forefront of that, and really one of the most fully realized models to accomplish those things. And then I think the other distinguishing characteristics of PACE still are that we are provider-led. So very successful provider-led model, able to accept accountability for a population that is entirely made up of older adults with complex needs, and have a long history of being able to manage the risk that comes along with that accountability and capitation. And then I think the other thing is just the high degree of integration and coordination of care that enables us to help people continue to live in a community-based setting, even as they face growing medical complexities and needs for physical and functional supports.
Peter, what is the, just moving on to the questions about the success, and what does the evidence tell us about the success of the PACE model? How do we look at essentially the value, and why is it important to essentially continue these efforts to expand? And at some point during the course of our conversation, I also want to talk about behavioral health, which has been much in everyone's view lately in terms of an area of focus and priority, and how PACE has begun to adjust to that. But first of all, how do we measure the success of PACE? What do we know about the evidence?
There's a long history of evidence about the success of PACE, as you might expect, given how long the model has been around. But I'd just point maybe most recently to an evaluation by the Assistant Secretary for Planning and Evaluation's office out of the Department of Health and Human Services that looked at different Medicare options for people who needed long-term services and supports. And it compared PACE to special needs plans for both the duals and the fully integrated dually eligible special needs plans. And what it concluded was that people who were in PACE were at a significantly reduced risk of hospitalization, rehospitalization, emergency department visits, or institutional placement in a nursing home. And that's very consistent with prior evaluations. In terms of cost, we do know that on average, Medicaid programs estimate that the monthly amount they pay a PACE program is about 15% less than the cost they would have incurred in their fee-for-service systems. And on the Medicare side, our reimbursement is very similar to Medicare Advantage. So our cost to the Medicare program is similar, but with higher value given that the outcomes that we're achieving for the population that we've enrolled.
Tanya, during the pandemic, as you noted, there were unique challenges presented to the PACE programs, and one of them was essentially the closure of a number of facilities, but particularly in the context of adult daycare. How did you adjust to that? How were we able to essentially respond to essentially those challenges as they arose, particularly given the concerns around congregate settings?
So one of the what I really appreciate about the PACE model of care is the flexibility that it allows organizations to have. During the start of the pandemic, Huron Valley PACE did not close. We reduced our number of participants coming in on site because our team quickly made adjustments to the needs of our participants. That's one of the things we're person-centered, and all the changes that was made, it just seemed like those were things that we were supposed to do because we are caring for a vulnerable population, and that's what we're here for. So, you know, when the pandemic came, our team it was just like a natural thing. We met, made changes, and I know some people say, you guys did all of that. I mean, but from a leadership and my team standpoint, we were supposed to do all of that. That's what the PACE model of care, and that is our mission, to make these changes to meet the needs of our participants. We stayed open. We realized that there are caregivers that, you know, they're working. There's a sandwich generation. We have people that are caring for kids and they're older adults with dementia. So our team developed a scale where they determined who was at highest risk, you know, based on needs that could be medical needs or need supervision. So we allowed we had those participants to come in, making sure that we could only transport one person on the bus at a time. We had to, you know, the infection control policies, keep people 6 feet apart. All those things were in place, but we were bringing in probably 10 to 15 participants a day based on, you know, medical and supervision needs. The other thing that we did, we also, at the beginning, we have a lot of aides that are young mothers that had no option. You close the schools down, we have no one to care for our loved ones. We took a risk. We opened up a daycare in our basement and had the caregivers to bring their, you know, the ones that had no options to bring their children in, but, you know, they stayed away from participants. We took infection control, temperature checking, and all those things. So we did do that. That lasts for probably the first 6 months of the pandemic until the summer came. We also turned our facility into a 24-hour facility. We went to churches, skating rinks, and got petitions. We rented some beds. It looked like we had a nursing home. We had a site that's secure, that block that was if people had COVID, that they would stay in there. Because some of the experience we had was we had participants that were going to the hospital that didn't have COVID, didn't have a place to go when they were discharged from the hospital. There was no place for them to go. So we had to take care of those who we are, you know, in charge of taking care of. We have to provide home delivered meals. Guess what? We couldn't get our home delivered meals. We purchased them from Gordon, couldn't buy them. But so we changed how we delivered meals. We work with a farm to table vendor in our community. So we said, well, not only will you deliver hot meals, deliver us more hot meals. We had to purchase equipment to package and freeze meals. So we were producing, we had to deliver more meals because a lot of the participants were not coming in a day center and they required meals. We had already did a food pantry. We increased the food pantry to also include staff members and participants as well, because our participants weren't able to get out to stores. We changed to telehealth. We started using telehealth. We got iPads. We hired a telehealth communication person to make sure pads were delivered, that they could be trained, used it out in the fields. We did so much. We did a lot of different positions. We're required to do daily touch-ins with all of our participants. We took a lot of the services that were in-house that traditionally participants came in to do. We OT, PT, doing a lot more home visit, nursing, EMPs out in the field. We bought equipment for participants to use to exercise, or activity kits and stuff, personalized.
So would you, hearing you describe all this, it tells me one of the beauties of the program is being really responsive and using what I call extreme common sense. And so the ability to do what's needed to get the work done, your comments about how people were cared for and people thought of different ways to do things. And so we're not in those silos only of what is regulatorily done, but making sure that people get what they need, to your point of the range of flexibilities. And I understand from talking to some other PACE sites that people were able to visit, families were able to be visitors to their loved ones. And so this separation issue that has been so painful during this COVID period was not what was experienced. So I was going to build one on examples of comments of how beneficiaries benefit, but also how providers do. And so the beneficiaries with the coordinated care that Peter and Sonia have talked about know that this team knows your background, so you don't have to repeat your history. If you're somebody who has a little bit of weirdness in your blood work, if you see another provider, people start doing new blood work. People know what your baseline is. You don't have to keep repeating things. And from the workforce, I'd like to talk about the direct care workers that are critical part of our team and our drivers. Oftentimes you don't think of that about these programs in typical Medicare, Medicaid programs, but the direct care workforce were sat at a table with the doctors, nurses, social workers. They contributed their observations. They were valued, and they are valued for what they know about the older person and the family. They are so key to this that the continuity of many of our direct care workforce has been for years, which is not a workforce oftentimes that has continuity. There's more turnover. From a professional provider, physicians, when we have formularies that they prescribe from, but if a physician thought that this particular person would only take one pill a day, even though the formulary said they should take another pill for 3 times a day, the physician or nurse practitioner doesn't have to call for approval. They can make that decision.
It's in the system. Do we expect that some of what you've described, Sonia, is really quite remarkable in terms of essentially the flexibility that Jenny also underscores? Do you anticipate, and I'm interested in Peter's thought on this as well, in how the PACE programs have responded to this issue? And again, at some point, I do want to come back to the question of behavioral health as essentially an increasingly important component of these services. Do you anticipate some of these changes remaining in place? You've adjusted a variety of things, but I'm wondering, with all the PACE programs, having lived through and survived through essentially this pandemic, you mentioned telehealth. Questions about whether telehealth continues to remain a critical component of the delivery of services. Do you anticipate, each of you, that some of the changes that the PACE programs have put into place will in fact be maintained, notwithstanding sort of the hopeful end of the pandemic in the near term?
I'll just jump in because I also
Go ahead,
wanted
Peter.
to circle back to your earlier question about what do we know about the effectiveness of PACE, because in regard to
Right.
COVID, we know that PACE participants, all of whom are at a nursing home level of care, experienced a third of the COVID-19 infection rates of nursing home residents and a third of the death rate from COVID of nursing home residents. So everything that Sonja described that she and her colleagues in the PACE community were able to do worked remarkably well. So we have that evidence as well. In terms of what will stay, some of these flexibilities were enabled due to flexibility under the public health emergency associated with COVID. And we have asked CMS to extend those flexibilities beyond the public health emergency because of the effectiveness that we've seen for the population. So Sonja, I defer to you, but I think what I hear from organizations in our membership is a really active rethinking of the role that the PACE Center plays. Will continue to play an important role, but how flexibly can we use that as one of the many resources that we bring to bear in caring for our participants?
Yes, I agree with Peter. I think like we're definitely want to keep a lot of the changes that we made because we feel like we can meet more people, serve more people, like being a little bit more flexible. In the past, like sometimes we think that, you know, participants have to come in the day center for us to, you know, keep an eye on, but we put things in place where we can monitor and provide that oversight in other ways. So I am sure that we will keep a lot of them.
A lot of
you
this.
know.
So one of the questions, you know, the obvious question is, given the success that Peter's identified, given the flexibility that Sonja's described, given the sensitivity of the population that Jenny's touched on, what are the barriers? I mean, one of the questions that arose initially, as Jenny knows, was the question of scalability. And it was something we struggled with for a number of years. And so there are unique characteristics that made Unlock special and successful. But again, what are the barriers that exist that essentially make it difficult? We know that there are PACE programs in 30 states across the country. Enrollment in the programs remains relatively low. I mean, we heard some of the statistics mentioned in the outset. What are some of the barriers that contribute to PACE eligible individuals either not enrolling or PACE programs themselves not being established? Peter, do you want to comment from the view of the PACE Association, and then certainly Jenny and Sonja? I mean, what are the barriers that we should be dealing with?
Yeah, I do think some of them are structural, and I do think some of them are changing. So it's tempting to think that a program that began at Unlock 50 years ago, you know, at this point in time should be sort of fully hitting its stride and maximizing its potential growth. But if you look at the evolution of the healthcare system, much of that healthcare system is just now, or maybe just within the last 5 to 10 years, catching up to the innovations that Unlock created. So for much of those 50 years, providers were not interested in being capitated. So holding forth a model like PACE that asked that of them was not something where we were seeing a lot of sponsors take that up. And we still see, even with all of the efforts at CMS to integrate the Medicare and Medicaid program, we still see those programs not being fully integrated. In fact, even within our own regulatory structure at CMS, we are regulated in part out of the Medicare Advantage side and in part out of the Medicaid side. And I think so some of the federal regulatory structures and perspectives are still catching up to PACE. And then I guess this third kind of hybrid feature of ours is that we are a provider and we are a plan. We directly provide care, but we also contract with hospitals. We don't open up our own hospitals mercifully, right, Jenny? That would be a tall order. So I think those are some structural barriers. I think some of the other barriers around opening up PACE centers can be addressed with adequate access to financing. We're starting to see that happen in the PACE sector. We at MPA, you mentioned, Sheila, my work on the PACE 2.0 initiative. If I could just briefly touch on that. That work is funded by the John A. Hartford Foundation, Harry and Jeanette Weinberg Foundation, and West Health Policy. And essentially what we're looking at is three sources of expansion for PACE. How do we scale up currently operating programs so they can serve more people in their community? How do we bring more programs to unserved communities and spread the model's availability in that way? And how do we expand the scope of the populations that are eligible to enroll in PACE and that can afford the program? And it's that last area, we call it our scope growth source, where we are particularly interested in the affordability barriers faced by Medicare-only beneficiaries who would greatly benefit from this program. But again, because of some structural issues, they're not currently able to afford it. And maybe I toss this to Sanja, because Sanja is one of the programs that has worked with us in PACE 2.0 on scaling and serving more people in the community. She may have some thoughts on what works there. Sanja?
Peter, before asking Sonia to respond, because I do want to hear what she sees as some of the barriers, but talking specifically about PACE being unaffordable for Medicare-only beneficiaries, you want to spend just a moment explaining that so people understand?
Yes, a significant financial barrier is the Part D coverage that comes with PACE. Essentially, PACE came before the Part D plan benefit. The Part D plan benefit was designed for Medicare Advantage and fee-for-service and did not take into account the fact that PACE was already a fully comprehensive program with no copays and no deductibles. As a result of those features, a PACE Part D plan can cost a Medicare-only beneficiary almost $1,000 a month, whereas they could get much more affordable coverage in the marketplace at about $40 a month. So we may get to this later, but I think one solution we're very interested in is, could we give Medicare-only beneficiaries a Part D plan choice? Let them choose the PACE Part D plan if it's the right plan for them. If it's not the right plan for them, give them a more affordable option. I'd say that's the most significant financial barrier right now for Medicare-only beneficiaries.
Sonia, comments on barriers in terms of sizing both, and then I'm also interested in having both you and Jenny talk a little bit about the fact that we only have a limited number of people, 58,000 people participating. What's stalling the sort of progress towards more people enrolling? But barriers as you see them, Sonia?
I think one of the main barriers is understanding what the PACE program is, getting that word out about what this program is. So many times politicians or, potential enrollees or family members come through and you tell them about PACE. They're like, oh my gosh, what? It's unbelievable. It's like there's a hidden secret and only certain people are supposed to know about it. So understanding what the PACE model is, there are federal guidelines or restrictions about how we advertise or market. So I think that is probably one of the main barriers. Another one is some states, in Michigan, we have a cap rate, a cap census, enrollment every month. So we can only net 10. So that is a barrier. And then sometimes when you want to expand to a different zip code, there are all these things, checks and balances through the CMS and the states that you have to go through. And sometimes for organization, there is a cost because you have to do a feasibility study if I want to get zip code 42889, which I just made up. But, and that's a cost. I would have to go out and get a consultant and do those things. And that's a cost to my organization when I would rather invest that money into participant care.
Got it.
And I'll let Jenny.
Jenny, you want to answer? And I am watching carefully. We could go for some period of time, but we don't have a lot of time. So I want to get through some of these questions, but we have some wonderful questions from the audience that I want to turn to quickly. But Jenny, other sense of the barriers and what we need to begin to address?
Yeah, I want to re-underscore the fact that PACE programs oftentimes have been capped, meaning only limited. So it's not like anybody can start it. A state must basically having it in its state plan. So that has changed. I think especially COVID has opened up, the awareness. Secondly, I think that when Sonia says that families are so surprised that there's such a program, can you imagine what that means for state policy people who see Medicaid as their responsibility and Medicare over there? This reframing is very, very difficult. And to this day, we know how difficult this still is. So that has been at the policy level, whether it's the state policy or otherwise. And implicit in that is the sense that these are not just medical care services, which is where the quantification and the so-called ROI is. It takes a reframing of understanding
what it looks like.
Social care. The Chronic Care Act recently, just has started to open up that transportation and food might be a part of well-being. It takes a big restretch from the way statutes are written and regulatory measurements are. So that shift is one of the big conceptual barriers of reframing what it takes to take care of people who are at this stage of life with this complexity of medical conditions, cognitive conditions, behavioral conditions, and functional needs. So that's work that is evolving.
Got to do it. Let's go to a series of fast-paced, quick questions and answers, and talk about some of the issues that our audience had asked us to talk about. One is a fairly straightforward. Are rural communities participating in PACE? Do we have many rural participants, Peter?
We do. We have some entirely rural programs, and then we have urban-based programs that have sort of a spoke service area extending into rural. And I've been looking at this recently, and a striking thing to me is in most of our urban PACE organizations, they're serving about 10% of the low-income older population that needs long-term services and supports. In our rural areas, our rural PACE programs are meeting the needs of more than 1 in 5 of those older adults. So the scarcity of options in those rural areas is really increasing participation in PACE.
A question, do we have data on the services that are most frequently utilized? And looking at the PACE programs, can we sort of capture what tends to be the thing most drawn on? What do we know and what data do we have available? Jenny, Peter, Sonia?
I was going to turn to Peter and Sonia because they know the distribution.
So do we have data and what do we know?
I mean, I would just guess out the top of my head, like just based on our program, like, home care services are utilized a lot. I mean, of course, our medical services, we have probably a little over 50% maybe use some type of home care service that we provide. So, I mean, I'm sure there's numbers, but it just seems like everybody, I mean, they use everything. So, we provide a lot. So yes.
Peter, is there data? Is there collective data? And I assume there is.
There is. So we collect, it's a voluntary data benchmarking system called PACE at the National PACE Association, and we do collect utilization information there. So we do have a sense of, being a community-based program, as Sandra describes, home care, transportation, the PACE Center, and then at the PACE Center, the primary care, rehab, meals, nutrition, and activities. These are really the day-to-day part of the model. Our hospitalization rates are relatively low given the complexity of the population we serve. And as I mentioned earlier, emergency department visits are low. So yeah, we do have data.
Data's there. Interesting question. Does a patient transition to PACE from a PCP who has cared for them for a number of years? How would that PCP essentially remain involved, if at all?
So yes, they can. I think Peter can probably correct me. Like there was policy in 2019 that allowed more collaboration between PCP and our PCP, because our provider will become the primary provider. But
Okay.
so there was like policy change that allowed some more flexibility. So yes, we do have participants that may come and be very reluctant to change over. So it is kind of a handoff, or and they could go back and have some appointments with their primary care physician. Like we're doing that with our medical director is from the University of Michigan Geriatrics Department. So we contract. So with that, she has her fellow physicians that they've been with them a long time. So she works with them to kind of transition them over, and eventually they trust the provider in our care, and it doesn't take long for them to adjust and be excited about being, moving.
Is it a relatively seamless transition in terms of the movement from a PCP into a PACE program?
I think so. I think it just depends on the program, like from our relationship with the University of Michigan, because our medical director is also, working at the University of Michigan. So it's easy. And
Yeah, can I ask Peter, is there PCP arrangements with the VA, with some of the sites, the Veterans Administration?
I not contracted because of the challenges of integrating different federally funded programs. So we don't have PACE organizations contracting with VA primary care physicians, but we do have PACE organizations serving veterans. And there we are, coordinating in a more informal way. But what Sanja's referring to is we did recently get a change in the PACE regulations that allow more collaboration between PACE and community-based primary care physicians. And the question there is always, can we maintain the integrity of that interdisciplinary team process? Can we find a community-based primary care physician that is willing to engage with that team? Because having the collective knowledge across all of the different disciplines and elements of care is really part of what makes that interdisciplinary team be so effective.
A quick question going back to the issue of behavioral health. A couple of folks have asked essentially the sort of approach that PACE is taking to the integration and availability of behavioral health services, and whether this has gotten new attention given the sort of increasing focus on the absence of providers, the absence of services, and how PACE is addressing that. Peter, Sonia, either of you?
I love to start on that one because, the PACE organization, the model care, we provide all levels of care, and behavioral health is one. And with older adults, there is a need. There's probably, and could be a new data on it, but between 70 to 75% of our participants have some type of mental health diagnosis, right? Mm-hmm. So, but even before the pandemic, we had started developing our own behavioral health program. Mm-hmm. But we had to really jump into it really quickly because the pandemic created all of these things that may have been, kind of not at surface, but with this whole pandemic, isolation created some issues that arose and needed more support services. And we were lucky enough here, Huron Valley PACE was selected to participate in the behavioral health integration program that was offered by the National PACE Association. And Peter could probably add more, but we participated in that. We have, we contract with the University of Michigan Geriatric Psych Department. So we have like our psychiatrist that's a part of our team. We have, behavioral health specialists, managers, inside of our department. They're part of our IDT. They sit in on all the IDT meetings. Yes, so it's very, very integrated. And I think most PACE organizations, they are If they haven't, they're moving towards making sure that those services are, at the,
Available.
yeah, well, they are available, but making sure that they are, at the highest quality and level, because there's definitely has been an increased awareness and need. So we all offer them, but, trying to definitely improve. And I hope I'm not speaking out of turn for any organization.
Peter, anything you want to add to that?
No, I mean, as Sandra said, she's done great work there. I think what's exciting about behavioral health integration in the PACE care model is we can talk about behavioral health, not just with a primary care physician, but with a PT, with a driver, with a home care worker, and really help them feel more comfortable and confident and more able really to work with people where behavioral health is one of the factors they're dealing with along with their physical health. And I was going to actually ask Jenny, because you mentioned she's been working on the California Master Plan on Aging, and I saw in there, Jenny, there's a reference to the increased risk that older adults face for behavioral health and substance abuse issues. And I think you drew attention to that very clearly.
One of the practical questions being asked is, of the folks that work for the PACE program, whether it's nurses, whether it's community health workers, physicians, and others, where do they tend to be based? Are they mostly in the field? Are they physically in one location where your population is served? Are they sort of on the road? Where are most of the staff located in the PACE programs?
So pre-pandemic, most of the staff were in the day center. Everything was ran out of the day center. But as the pandemic came, and still it's a combination. We have OT-PT. They may have, we bring people in for OT-PT therapy because we have different equipment. They go out to the homes. So social workers are in and out homes, the facilities. So it was before, but it's more so now. It's very diverse in providing care.
Practical question, may someone enroll in PACE at any time, or there are limited enrollment periods?
Well, it's not like MA where you have that one annual enrollment period, but we do have first of the month effective enrollment date. So you can enroll throughout the year, but if you're in the prior month, you have to wait till the first of the following month.
Got it. But it's continuous through the year. So someone can make that decision at any point in time rather than waiting for, as you suggest, an annual enrollment period, I think is exactly right. One of the questions that, again, people are asking about is how one makes this decision and how the integration takes place. And when we talked about the barriers, the sort of intersection between the states and the federal government, you're dealing with Medicare at the federal level, you're dealing with Medicaid at the state level. Are part of the barriers we're confronting the intersection between the two? Is the complexity between managing between Medicare and Medicaid part of the problem in terms of letting people know, coordinating between the two programs, combination of services?
I'll take that from a policy perspective, and Sandra can, I'm sure, think about it. She's worked at it on the ground level where you're trying to get somebody qualified and enrolled in the program. But I think one of the policy issues right now is that states have launched managed long-term care for their Medicaid beneficiaries. Their options counseling systems and enrollment systems are only designed and equipped to enroll you in a Medicaid plan. They are not designed or equipped to enroll you in an integrated plan like PACE. So there's been no integration of those systems with Medicare enrollment, and you can't enroll in PACE unless you're enrolling in PACE for both your Medicare and Medicaid benefits. So I think that is a structural problem we're facing. But Sandra, do you want to talk about, I know you actually did some specific work on this in PACE 2.0 on kind of reducing the number of days it takes for somebody to get into your program.
And Sonia, I will tell you, we have essentially 1 minute remaining. So I'll ask you to quickly respond and then ask if any of our terrific panelists have anything else they want to add at the very end, sort of a quick summary. But Sonia, do you want to quickly comment on that? And then
there are as in my state, barriers to enrolling is not a seamless process. A lot of work where it can take, could take up to months to get someone enrolled that really needs to.
Got it. Got it. Last comments from any of you? It's been a fabulous discussion. We could go for some period of time. We got a tremendous amount of interest. This is a topic that the BPC is going to be continuing on. We're going to continue our work in this area. But anything from any of the three of you that you want to sort of throw in at the end?
I'll do one and end with the beneficiary. Does this get complicated for the beneficiary once he or she gets into the program? The answer is no. They don't have to go and take a look at what they're qualified for and whether it's a Medicare benefit or it's seamless. So they're like the duck on top of the water. It's the PACE program itself that's swimming like crazy underneath, making it as easy as possible for the beneficiary.
Got it. Anything else, Peter? Sonia, any last comment? Well, let me thank you. Sonia, go ahead.
No, just thank you for the opportunity to share. Love to talk about PACE.
Great. Well, it's been a great conversation. And again, lots of work yet to be done, lots of problems yet to be solved. But, 50 years in some respects is kind of a blink of an eye. And so we've come as far as we've come, but we have a ways yet to go. So thank you, all three of you, for joining us this morning. We really appreciate it.
Thank you.
Thank you.
Thanks on behalf of BPC. Thank you.
Thank you.